All right. Good morning, everyone. Can you hear me? All right. Great. Good morning. Good morning. Hope you are home safe. For those who are still in the dorms, have a very happy Thanksgiving time. Enjoy with family and friends. Have a good time. But don't forget renal. I tell you, take a day off tomorrow, relax, do your stuff, but back to studying on Friday. Okay? Yeah, renal is little tough, so you wanna be ahead of the game. Finish everything beforehand, because next week is the only time you are having everything congested there. So yeah, just finish it beforehand. All right, what's the time? Oh, almost 10. Okay, we can get started. I will be recording this and share with others who are not able to attend. But let's get this going.
Recording in progress.
All right. Did everyone get a chance to go over this slide yesterday? Did you try to put in the dilators and constrictors as I had told you yesterday? Did you try or no? All right, let's do one more question and then we can go from here and see how you are doing. I'm not running the poll for this question, but just tell me if you got it, raise your hands, and we can go accordingly. Any volunteer for this? Angiotensin 2 at low levels, and then sympathetic stimulation of alpha 1 receptors. What do we mean by that? What's the role? Why do they have opposing effects? Can anyone explain? Yes, Adam, please go ahead.
I'm a bit confused, but from what I understand, I believe that the sympathetic nervous system mainly acts on alpha 1 receptors that are more prominent at the efferent or afferent with A arterial. But when you have angiotensin, when it's high, it mainly affects the afferent arterial, and when it's low, it affects the efferent arterial more.
Beautiful. Yeah, I will explain it in a minute, but just keep in mind that sympathetic stimulation, whenever it's happening, it has to bring the GFR down, right? So how does it bring the GFR down? It has to be working on the afferent side, so it can constrict the afferent side going into, yes, JP, you are correct. So basically, what is happening here? So let's take this example from here. So let's say we are talking about alpha 1 receptors, which are sitting on the afferent side, and sympathetics is a very good example here. So this is in a situation, some anxiety or emergency situation, right? Where blood pressure is rising and everything, right? Your sympathetics are working on alpha 1 here. They're going to constrict this side. So your glomerulus, the capillary network, which is going into the Bowman's capsule head of the nephron, right? The blood flow is going to decrease here. Is that clear up to this point? And that's going to bring the hydrostatic pressure down. And I told you yesterday, your hydrostatic pressure in the capillaries, that is the main thing which is driving the filtration pressure. The net pressure would be always main work of this PGC. Or if someone has more proteins in the blood, that's going to impact, like bringing the filtration down. Does that make sense to everyone? Is it clear up? Erin, are you good?
Yes, thank you.
Yeah, up to this portion. Now let's talk about the low angiotensin levels. So low angiotensin levels, they work differently. So their major action is at efferent side at the low, low levels. That's gonna block the efferent on this side, and this will have the blood flow sitting here for a longer time. Is everyone understanding that, right? So you're gonna have your PGC rising here, and if you have your hydrostatic pressure rising, of course, your GFR will be increasing. Make sense? If PGC is high, your filtration pressure is going to be high, and that will bring up your GFR. Make sense? That's just the low levels. But in case, let's say, when is your RAS system activated? Can anyone answer that question? Yes, Amir, you are correct. Blood pressure is low. That's one example, yes. Hemorrhage, right? Hemorrhage is a very good example. So body is trying to build the pressure up in order to avoid the hemorrhage derived low blood pressure there, right? Your angiotensin 1, so your renin system, RAS system. So renin activates or it stimulates angiotensinogen into angiotensin 1, right? So now what's going to happen? Angiotensin 1 gets converted into angiotensin 2, which is, as the name suggests, angio means blood vessels, right? Tensin is the tension. So just how the name drives, so angiotensin 2 high levels, they're gonna impact on the afferent side too now. So earlier we said, yeah, efferent arteriole is constricted here. So your GFR was slightly higher at low levels, right? But if you have angiotensin 2 at high, now your afferent side will also be constricted, which is gonna bring GFR slightly down because you are constricting here on this side. So this is gonna bring the overall PGC down, and that will bring the GFR down. Does that make sense? That would be high levels of angiotensin 2. Is that clear or no? Everyone good? Any question? Okay, so now the chart that I had given you, right? So let's say, give me the examples here. So if I ask you, you have a candidate or vasoconstrictor sitting here, what comes to your mind? Anyone? What's the candidate? Yes, Erin, please.
Well, this would be like sympathetic nervous system, so it would constrict there. You'd have less blood flow going through and therefore less filtration.
Beautiful, beautiful. So you have alpha-1 receptors getting constricted here. Your catecholamines, they are in action, right? So they're going to decrease the PGC, right? Your RBF is decreased, and so does your GFR. So the next slide, I have left it empty for you to work on tonight. That's your homework for tonight. So just please work on that. So if I say, you have a candidate here working, what it will be? Anyone? Yes, kind of. NSAIDs too, and we'll come to that, Abram, just in a second. That's related to the same question. Yes, low angiotensin. Very nice, Abdul. Thank you. So low levels of angiotensin 2 is going to work on your efferent side, and they'll have slight positive effect on GFR, okay, at low levels. So they kind of protect kidneys during this time. What about this one? Dilation of afferent side. Anyone? Dilation of afferent side? Yes, very nice. Abram, prostaglandins. Yes, NO2 does the same thing. So basically, prostaglandins have a very nice effect on both afferent and efferent side. So if you think of this one here, the left figure on the left is the same thing basically, but this is the major effect of prostaglandins, which is going to dilate the afferent arteriole and does protecting your kidneys. So the reason I was telling you, like the question that we had yesterday, somebody who's on NSAIDs, so they don't have this dilation by prostaglandins here because prostaglandins are not in the picture there, right? So what Abram was mentioning earlier, yes, Maram, you are correct. So what you are mentioning, Abram, if you are giving someone NSAIDs, you basically taking this effect out. Okay. Yeah. So Aaron is asking, are there any that are specifically afferent versus efferent? You mean dilation?
Yes, like I know we said prostaglandins vasodilate both, but are there any that vasodilate just
They're pretty
afferent or
much
just efferent?
having effects on both sides, and
Okay.
those who are vasodilators, um, they mainly tend to work on afferent side more. So that's what is going to bring the GFR up, right? So
Yes,
yeah.
got it.
Yeah, but we will talk about, there is one more thing that I'll bring, like next question is coming, so I'll explain you a little bit more that we have some more candidates that work accordingly, and they will bring those changes. Abram has a question. Yes, Abram.
For this, for efferent and afferent, for that works on both. For NAT, would you consider like the macula densa sensing?
Yeah. That's what I was going to say. So we're going to talk about it. I have question coming up. That's why I wasn't explaining it yet. NO is the same. NO is the same dilation. Yes, it's a vasodilatory effect. Okay, so this is for you guys to work on tonight. Put your candidates up, go through the book, and find those candidates and put them up. Okay, which is afferent, which is efferent, which is both sides. So you're ready for the exam. Because the exam questions not going to be straightforward for you, right? So if I'm asking, okay, if GFR is rising, hydrostatic pressure is higher, where do you think this candidate is working? Where do you think that what is happening to the hydrostatic pressure, for example, with this candidate or that candidate? So just prepare yourself for a clinical STEM and with different candidates in. So basically, when you look at a question in exam, it's asking you one final question, just giving you a scenario, just so you guys are prepared for the board exam style questions, right? That's the only thing. Okay. Thank you, Andrew. Keep putting these things. Yeah. Endothelin is another one which will constrict. Yes. Okay. All right. So let's get going. Sorry, this is a big slide. So I put everything, but later for you guys before you work on it. Okay. So this is the same thing again. You need to know your filtration pressure is a workup of these three items here. Major driver would be your PGC. That is your hydrostatic pressure of GC stands for glomerular capillary. So P is your hydrostatic pressure. Here, P is your hydrostatic pressure for Bowman space. right? BS is your Bowman space. And then you have pi GC, that is the oncotic pressure on the glomerular capillary. That's because of the proteins which are not getting filtered and they are still staying in blood here. Is everyone clear about this concept? Yes, okay. So, people who are on high protein diet, they will have low GFR, right? Because the oncotic pressure built up with high protein diet is going to overcome the PGC, right? So they will have low GFR that way. All right, so let's get going. Again, how does renal vasculature regulation would impact the RBF? That would be your question. Which are the hormones, which are the different metabolites that work on constriction and GFR. So here. All right, next question. Now, you tell me. Just read it well, think about every option, and then give me the right answer. Any volunteer? So we are talking about macula densa now. The candidates there are which ones? Okay, Aaron, please go ahead. Thank you.
It is adenosine, which decreases the glomerular filtration rate because it's basically sensing more solutes due to an increased filtration rate, and then it does that negative feedback essentially.
Beautiful, beautiful. Thank you. So in case now the question goes back, why do we need this juxtaglomerular complex? Why do we need macula densa and what is it sensing? So in any scenario where GFR is high and this macula densa is your sensor system, which is sensing sodium and chloride, basically, they say, but it's just a hypothesis at this point. No one is sure, like, what solutes is it really sensing. But in case GFR is really high, the macula densa, which sits very close, so it's basically on distal convoluted tubule, but it is very close to the glomerular complex. So let me bring you, I'll come back to this question and we'll discuss all the options later. So let's first try and understand, why do we need this? So here is your distal convoluted tubule making a loop here, but your macula densa or juxtaglomerular complex is sitting right here, which is basically secreting some of these vasoconstrictors or dilators, some points, which are working on afferent and efferent right here in order to take care of the regulation of GFR from here. Why do we need that? First thing is that, yes, Abram.
So like for the macula densa, it's a self-regulatory for your nephrons to see if you're losing too many ions or too little. So this is the body's way of self-checking itself because it's the last opportunity before it's being excreted.
Beautiful, beautiful. Couldn't be excellent answer than this. Thank you for sharing. So see, there is another thing to it. We have blood pressure changes throughout the day, right? Or someone who's really hypertensive, you have more pressure sitting on the vessels. And now, how do you regulate that blood, which is coming from, let's say, the renal artery is bringing blood to these capillaries now, further down, right? There are pressure changes happening up there in the body. How do you regulate that blood coming into the renal area? Otherwise, you're going to bring a damage to the renal vessels, right? If you don't control that blood pressure accordingly or blood flow accordingly, there will be a damage here, right? And that's what happens usually if someone is hypertensive without treatment for a very long time, they eventually bring damage to the kidneys, right? So that would be stage 1, 2, 3, and that's how it follows. So there are two hypotheses like how to auto-regulate this RBF, and these are just hypotheses. Nothing is like very straightforward at this point. One of the hypotheses says it's a myogenic hypothesis. That means the muscles control on its own. So if they see the distend on the vessels beforehand, they gonna contract in the capillaries, like coming to the capillaries, the afferent arteriole is already having a contraction, which is calcium induced, and that's gonna regulate the flow. What is coming from up there is gonna auto-regulate it by myogenic hypothesis. So smooth muscle cell contraction is already taking care of it. Or second thing is this tubuloglomerular. How we call tubuloglomerular feedback. The name suggests on its own. From the tubule, the distal tubule to glomerulus, it's giving a feedback here, right? So that's what it is. So this hypothesis should take care of high GFR in case before body is losing too many solutes out. Now, kidney knows that we need to preserve, or the body knows that we need to preserve these ions for us, right? So don't let it go loose. That's what it is about. So your macula densa would sense it, and it's going to secrete those metabolites time to time, which will vasoconstrict the afferent side and thus regulate and then regulate the GFR further. Yes, Aaron?
Sorry, I just have a quick question with the hypertension.
Yes.
Would hypertension cause like increased blood flow and increased filtration, and you would essentially lose too many solutes, or is that the wrong understanding?
So
Like, how does the kidney damage occur?
yeah, so ideally, if there is more pressure, yes, it can bring high GFR. And that point of time, you need a contraction there, which will regulate the GFR.
Okay, that makes sense. Thank you.
Yeah, yeah. Yes, Samir. So complex would kick in to do more reabsorption. Yes, you are absolutely correct. Or actually, not reabsorption, but basically you are controlling the flow already. The RBF is being controlled, which is going to slow down your filtration or GFR as such. Okay. All right, so these are just the topics that we had discussed earlier. I brought the slide back in so you understand each one of these. Just remember that you're going to see questions on different calculations. So whether we give you clearance, GFR, or depending upon what we are asking, and you got to be ready with the stuff. Okay. Next question. Which one is cleared at the lowest rate? Anyone? Beautiful. Thank you. B is correct. Yes, you don't want to lose glucose out of the body. So it will be all absorbed back pretty much until or unless someone is diabetic. Dr. Shah should be talking about the glucose transporters and the maximum efficiency of the transporters. So if someone is diabetic, the glucose is going above the saturation level of the transporters that you have available, then glucose is just gonna spill back into the urine, right? So he'll talk more about like what is this play, how much maximum transport you have for glucose. But ideally, in a normal person, as long as they are not diabetic and insulin is taking care of everything and it's absorbed nicely, the body doesn't waste glucose in the urine. Okay. All right. How about creatinine? How did you get to glucose? Let's work on the other options. Yes, Chris, please go ahead.
Yeah, so for creatinine, this is pretty much completely filtered out. There's a little bit of reabsorption. And so this would kind of be the opposite of glucose.
Yes, beautiful. So, oops. So here, if you see, the creatinine is freely filtered, but it is not reabsorbed. It's going to be secreted like 10% over. And as I told you, creatinine is your endogenous marker to measure your GFR. So, you just can do it from your blood levels, basically. How much is normal? Do you know the ranges? What is a normal range that will tell that GFR value is in place? So creatinine is 0.7 to 1.2, 1.3 is the normal range. So, based on that, the GFR values are calculated. How about inulin? How is inulin cleared? And what kind of marker is it? Inulin has the highest clearance. Very nice. It's all freely filtered. Erin, what's your question about?
For creatine, we said it's like excreted, but also a little bit is secreted. How is stuff like secreted if it's not reabsorbed first?
Yeah, so creatinine works very different way. So when you will study the urine composition, you will see what I mean. So what happens that you first freely filter creatinine, but there is still some left here, which is gonna get secreted out at this point, almost
Makes
the
sense.
end. Yeah, to
So
make
it's still
the
in the blood. It was never filtered out, so it can be secreted out later on.
Yeah, it can be
Okay.
secreted later on because this is a metabolite coming out of your muscle function, right? So it's
Got
gonna
it.
be there, but there are different. I just don't want to go into the whole mechanism. So there are certain mechanisms that creatinine works under. So what happens that when you go down through the loop of Henle, there are certain portion of creatinine which are basically poured into the interstitial space. It's not absorbed. We don't call it absorbed, reabsorbed. It's in the interstitium basically. And that works on finalizing your urine composition. So this is called countercurrent mechanism. This will be probably the fourth week of renal. And Dr. Shah will cover it. I'm just not going like into too much detail of that yet, because I just don't want to confuse everyone at this point, but it has a major role to play there. Yes, Abram.
So when we are doing the values just to compare it to like average or normal, we only compare it to values in that class and not osmolarity.
Oh, yeah, everything has to be taken into consideration, Abram. So
Okay.
that's why I've been telling you guys, that's why students sometimes have hard time with renal because they don't see the full picture. I am just starting with the basics, right? So Dr. Shah is going to start with sodium. How is sodium getting reabsorbed? It's 99.9% sodium is going to get reabsorbed and water is just going to follow, right? But it has certain mechanisms that it will be playing on. And so is potassium. Potassium has to be, again, reabsorbed and some excreted. Calcium it will be again reabsorbed back. How much percentage sodium is getting picked up at proximal convoluted tubule has a major role to play versus how much percentage is getting picked up at the distal convoluted tubule. And there are different transporters. And those transporters, they work under diuretics. So, when we talked about the treatments, like why diuretics are being taken, as the name is suggesting, this is for more urine production, right? So you got to send sodium out of the body, right? You got to excrete more sodium out. So those are those treatments for. That's why I'm not touching that portion. But what Erin was mentioning and you were mentioning, there are percentages to each ion, and that has a big role to play for your final urine composition.
Okay.
And it works with the interstitium. There will be things or solutes that will be sent to the interstitium. So they are creating an osmolarity out just outside the nephron. They're not being reabsorbed yet into the blood, but basically they are staying in the interstitium. Erin, are you getting my points on the side?
Yes, thank you.
Yeah, so when you get to the final part of the renal completion, like full, then at that point you will be getting the final urine composition and how the osmolarity is also taken care side by side. We call it countercurrent mechanism, where this tubule is running along with the interstitium and talking directly with the interstitium. What is the osmolarity outside and what is the osmolarity inside the tubule?
Okay.
So that's how it would work. That's how your solutes will come out and in. And there are certain portions of your thick ascending limb, which is not water permeable. These are thick membranes, so they're not water permeable. And that will have another role to play finalizing your urine composition. So he'll talk more. I'm not going there because I don't want to confuse everybody else who haven't read yet the rest of the portion. But this weekend you should spend and finish it all. So when Dr. Shah is teaching, you get full final picture. Okay. All right. So inulin is freely filtered, right? It's not getting reabsorbed or secreted. So just keep that in mind, right? What about pH? pH? Anyone? pH is mostly, so here 20% will filter out. The rest will be still. So that's why we consider it a major marker for renal blood flow or renal plasma flow, right? So when it's coming here, 80% of this will be secreted back. So finally, it will be excreted out, but 20% from freely filtered and 80% secreted. Amir, yes?
Hi, Dr. Kaur. Sorry, I was just looking at this again. Could you clarify, like, I understand the secreted portion, but could you clarify the 20% filtered and 80% secreted, just so I understand the clearance aspect?
So see, I told you yesterday that we use pH as a marker for how your renal blood flow is, right? So this goes into the blood flow. Only 20% will get filtered out here. And rest is just going to go back through the efferent arteriole, right? So efferent arteriole, when it's running close to the tubule, finally it's bringing 80% back here through peritubular capillaries, which are running along here. You see my point?
Yeah, that makes sense because I looked at it. I know that inulin is the marker for GFR, so I'm just trying to get it. Okay, yeah, that makes sense. Thank you, Dr.
Inulin is all freely filtered, but
Yes.
since this stays in your renal blood flow, this stays in your efferent arteriole, this tells us how good your blood flow is here, right? So 80% will be secreted out later. So finally you'll have, so the time taken when it finished that blood flow and then, it got secreted back here, you will know how, how we were having the formulas yesterday. So what is there in the urine for pH, right? And what is the urinary flow rate? And divided by what was injected in plasma. That will give you effective renal plasma flow value. Why I'm saying effective renal flow value? Because some very small percentage of pH still stays back in the body. Very small. So they just overestimate it like 10%. And that's how you'll get that value. Is that making sense?
Yes, got it. Thank you, Dr. Kaur.
Okay, thanks. Yeah, so that's what I was talking about. So if you really want to have the golden value of your renal plasma flow, you want to know what did you inject in renal artery. So you have to sample renal artery, then you have to sample renal vein, which is very difficult to do, right? Instead, you just do effective renal plasma flow and just overestimate by 10%, and that will give you effective RPF for someone. Clear? Everyone good? Okay. Wonderful. So yeah, just make sure that clearance, GFR, all those calculations, you should be ready. Now I'm coming back to our box diagrams, and I hope everyone is good with this, but raise your hand and then I will know how you're doing. So if you wanna build up the ECF, what will you give your patient? And please draw it out when you do it in the exam. That's not correct, Andrew. I'm sorry. Read it well. B is not correct either. I'm sorry, A is not correct. Yes, Erin. C, finally, you gave me all the options. Okay, Erin, would you like to explain, please? C is correct. Yes, C is correct. How do you build up ECF volume? You decrease intracellular. That's another, thing there in the stem. And overall, you are increasing total body water. Yes, Alan, beautiful. Abdel, go for it. You got it, Alan.
Hi,
Thank you.
Dr. Carr. Is it because it's hyperosmotic, so the water would come from the intracellular to the extracellular fluid to compensate, then it's gonna increase the extracellular fluid?
Beautiful. Beautiful. So you want to create hyperosmolarity outside in ECF to draw more water up from the cells, right? So that's how you would decrease the intracellular fluid volume. Yeah, and build up the ECF. And why dextrose is not correct? Did you get the point now? Someone, Andrew, you had said E, right? So you got it now? So what will happen? Would you like to explain it? Did you get it?
Oh, yes, thank you. Yeah, I got it. Yeah.
Would you like to explain it? I wrote it up there.
Right, yes, thank you. Because once basically put the sugar in, it kind of just stays in the extracellular fluid. It's only going to draw fluid into the extracellular fluid compartment. So yeah. So I
Yeah.
got a little confused with that.
So basically, if you are giving your patient 5% dextrose, right, this is sugars. So this is going to cross the membrane, get it to the cells, and you are making cells hyper osmolar now, right? So now you will draw water inside the cells rather than building up your ECF. So that was the explanation for that. And 0.9 is just isotonic, right? That's not going to build up the fluid volume for you. It's just isotonic, right? 0.445% is hypo. So now your volume is again going to go into the cells. Is everyone clear about that? You got to draw it out tonight and go over this so you can answer questions. Ellen, what's your question? I was saying that you got to be ready with the question can be any, but the formula is same. If I go back here, what I was trying to say, if I give you a question for clearance in exam, this is your formula, right? What is there in the urine and what is urine flow rate and what did you inject in the plasma or how much molecule is there in the plasma? All the formula, if you see, they're basically talking about the same thing. UV plasma, UV plasma. This is pH. This is just any substance that you're talking. And if you're talking about GFR, this is going to be inulin. Make sense, Alan? Alan, did you get it? Okay. Amir. pH has more clearance. Where did you read? In the textbook? Amir? Okay, I got to check it. I mean, clearance is clear. What is clearance? Clearance is if you get rid of everything, what is sitting in the plasma. What did you inject? Whether your kidneys were able to clear everything out. That is your clearance. So I believe some of pH still stays back in the renal vein. So I got to check that before I say yes to you. So I can't recall that, Amir. Okay. All right, let's get going. Let's do more questions before I leave you. And then you can prepare yourself. All right, so 2 liters, someone who's drinking 2 liters of water, what do you think they did to their body? Okay, Erin, please go ahead. Thank you.
Would it be C? Because when you're sweating, you would increase your osmolarity in the ECF, so water would move that way first. Then when you drink lots of water, you're then making it less concentrated in the ECF. So now it's hypoosmolar in the ECF, and water will want to move into the ICF.
Beautiful. Beautiful. Very good explanation. And until you draw it, I think you will get it. But those who are just doing in their mind and still getting to the answer, great. But I would suggest, if you have scrap paper on the exam, just draw it out. Why won't you do it and just do step by step and then you remember, okay, somebody who was exercising, they were sweating, right? So first of all, you need to know what were they doing to their ECF, right? And then if you added just clear 2 liters of water, it doesn't tell you there was any solute in it. So it's just making the ECF hypo. Now from hypo to hyper, it has to move inside the cell. So you will be building the intracellular fluid volume eventually, right? Your intracellular fluid volume is not going to be hypotonic. It was earlier, what was it? It was hyper, right? Now, extracellular fluid will be hypertonic. That is not correct, right? And then extracellular fluid volume will be greater. that is not correct either. Water is going to shift inside the cells, right? So please go point to point and then you'll get to the right answer. Okay, Michelle is asking a question. So should we practice using all the equations on that chart? No, no, no. You got to do everything, Michelle. Whether it's clearance, whether it's GFR, or anything else, you got to be ready. Okay. Michelle is asking if there is any specific equation that you should be working on. And I'm saying everything. This is your only chance. Before you go to second year, I want you to be full renal ready. Because renal is hard. Next year it's gonna hit you if you don't prepare it well now. All right, next question on your screen. Least likely, which one? Yes, Aaron, Abdul, A is correct. Very nice. Will you explain it, please, quickly, looking at the figure? A is the right answer. Yes, Abdul, go ahead.
Yeah, so for dehydration, we are losing water from the ECF, so the ICF would move to the ECF to increase it. But in this figure, we see that ECF is decreasing, so dehydration cannot be it.
Yeah, your first explanation is not fully correct, Abdul. So basically, you can go looking at the figure that there is isotonic fluid loss, right? Isotonic fluid loss is in which situation? It could be diarrhea, it could be hemorrhage, it could be vomiting, and that gives a patient isotonic loss, right? And that's what is happening. Now, if we talk about dehydration, what was happening there? Can anyone tell me what was happening in dehydration? Because Abdul's explanation, there has to be some clearance. Yes, Aaron.
Is this one similar to sweat in the way that you are essentially losing water from your ECF? So it's hyperosmolar there, so water will move into your ECF and the osmolarity will increase.
Yes, yes, beautiful. Okay. Well, secretory diarrhea is out of question here. And that's gonna be massive, but that's also gonna take a lot of solute out. So it may mess up the osmolarity. Diego. Is that clear?
Yes, it's just that if you're losing fluid secretory diarrhea, you're losing chlorine and then
Yeah,
sodium
it also
following after.
depends.
And then,
It also depends how nicely you are rehydrating your patient and whether you are giving them the minerals back or the ions back, right? So all those things go side by side. I mean, we're just giving you hypothetical, quick options. Okay, someone went to
thank
the
you.
bathroom 2-3 times, and what did they lose quickly? So yeah, osmotic diarrhea is not as impactful. So that could be, I mean, that can bring some loss, but it's as long as the osmotic particles were sitting in the gut, they'll get cleared up and everything is back to normal. Secretory diarrhea is very massive. So I think I would stay with the pathogen, which is not as fatal as secretory diarrhea toxins are. Yeah, you put me on the spot. Okay, so everyone ready for all the shifts and everything? Please make sure that you go over these questions, put them in some clinical STEM and finish the questions, right? Few more, then I'm gonna leave you with your Thanksgiving wishes and enjoy. All right, what is made in kidney? Beautiful. Erythropoietin is made in kidney, and it is sent to bone marrow. That's where it is helping for hematopoiesis, right? So patients who are having end-stage renal disease. So there are different stages for renal disease, right? Stage 1, 2, 3, 4, and then end stage basically. So renal failure, where the kidneys are not able to make erythropoietin. Those patients are given erythropoietin injections to keep up with their anemic conditions, right? Because their hematopoiesis is impacted as well. Now, where is 25-hydroxyvitamin D is being made? Beautiful. Yes, liver is the correct answer. Aldosterone. And you will hear a lot more regarding aldosterone from Dr. Shah next week. Aldosterone is being made where? No hypothalamus, Jasmine. This is from adrenal glands. Yes, adrenal cortex, right? Hypothalamus is just making the releasing factors. I'll cover it all in endocrine in January. We'll finish it all. And then angiotensin 2, where is it being made? Beautiful. So where is angiotensin 1 being made? So let's say your renin is in action and it's going to convert your angiotensinogen into angiotensin 1. Where do you think that is being converted? I know you covered angiotensin 2 probably in cardio. Liver is producing, Ashley, liver is producing angiotensinogen. The site for angiotensin 1 production. No Bursum, no adrenals. Yeah, I see. Blood. Yes, blood is the right answer. Bloodstream. That's where it is getting converted. ADH. Where is it being produced? Yes, Maram, you were correct. Hypothalamus. All right, posterior. Yeah, posterior pituitary release. It's actually secreted in hypothalamus and then stored in posterior pituitary and then get released from there. All right, wonderful. I think we're doing pretty good. I saw something in chat. Michelle, what did you write? I was wondering if there are any questions to practice. Yes, you'll have a Q bank for renal as well. Please check with your faculty. They have access to everything. All right. This